Good morning. My name is Vadim Goz. I'm a spine surgeon in the Reno Orthopedic Clinic. I'll be giving a 15-minute overview of the BPCI and BPCI Advanced programs. I would like to thank Dr. Vaccaro and CSRS for the opportunity to speak on this topic. We'll talk about the background in terms of the motivation of CMS to establish these programs, and we'll also cover the BPCI and BPCI Advanced, which is the current version of the BPCI program. The backdrop for these programs being established is the healthcare cost crisis, and at this point we're all aware of the issue, so we're not going to harp on the numbers too much. But in general, we spend almost 18% of the GDP on our healthcare system, which is a staggering amount and more than any other country. And it's debatable what we're getting for this money. So if we take a look at the graph of life expectancy versus healthcare expenditure, we see that the United States is way over to the right in terms of very high expenditure, and our life expectancy is not that high compared to other countries. Now, it should be noted that global health metrics such as life expectancy are very much multifactorial and are swayed by other variables such as obesity rates and socioeconomic factors. But in general, this doesn't paint a great picture in terms of the return of our investment as a country in terms of dollars spent on the healthcare system. In the early 2000s, this issue really became front and center for the media. This is an example of a popular article in the New Yorker by Atul Gawande that looked at two towns in Texas, El Paso and McAllen, that had similar demographics but drastically different costs in terms of healthcare delivery, and the higher costs did not correlate with better outcomes. As a matter of fact, they correlated with worse quality of care delivered in this example. And this article is really a nice microcosm of a more global problem in our healthcare system, in that the fee-for-service system incentivizes volume versus value. One of the thought leaders on the economics of healthcare is Michael Porter. He is an economist at Harvard, and his ideas on how to pursue value and value-driven healthcare really have permeated throughout government policy in our healthcare system today. He describes a six-component or six-pillar strategy to transitioning to a high-value or value-driven healthcare system. So pillar number one is change organizational schemes to integrated practice units, staying away from siloed care. For example, as spine surgeons, we should be seamlessly integrated with physical medicine and rehab physicians, as well as anyone else that's involved in the care of our patients. Pillar number two is to track outcomes and costs for every patient. As Mike Bloomberg says, if you can't measure it, you can't manage it, and you can't improve it. Pillar number three is to move to bundled payments, which is where this presentation comes in. Number four is integrate delivery across facilities. Number five is to expand services that work well across geography. So if you build a system that works really well in one place, go ahead and expand that system to other places. And number six is to build an informatics system that really enables all of the above goals. So the Bundled Payments for Care Improvement Initiative, or BPCI, was originally established in 2013 by CMS. It was part of the ACA, which established the Medicare and Medicaid Innovation Center, responsible for testing innovative payment models that reduce costs and improve care across federally funded programs. BPCI originally had four models that they tested. So model one included all DRGs, but only for the acute care. So that's the in-hospital Part A payments. Model two only applied to selected DRGs, but it applied to all non-hospice Part A and Part B services during the initial stay, as well as the post-acute period and any readmissions within the episode of care. Model three applied to all non-hospice Part A and Part B services, but only for the post-acute period and readmission, so it didn't include the initial hospital stay. Model four was the only prospective model, and it included Part A, Part B services during the inpatient stay and readmissions without including post-acute services such as skilled nursing facilities, etc. BPCI Advance is the current iteration of BPCI, and it started in 2018. It's expected to run through 2023. It includes a 90-day episode of care, including inpatient or outpatient services, physician services, readmissions, skilled nursing facility, inpatient rehab, LTAC stays, as well as home health services, lab services, DME, and all drug costs. So there is a lot bundled here, making appropriate risk stratification and tracking of costs very difficult and very much pivotal to any organization that takes part in BPCI Advanced. There are very few exclusions to the BPCI Advanced program. They include trauma, cancer, transplant, and ventricular shunts. There are some devices that are excluded from this program, but by and large, most episodes of care do qualify for BPCI Advanced. Hospital benchmark pricing accounts for patient case mix via DRG codes, demographics, overall resource utilization in 90-day period, hospital historical expenditures during the fee-for-service period, as well as a comparison to peer groups based on hospital bed size, rural versus urban setting, academical, medical centers, and a number of other factors. Pricing is also adjusted for the Geographic Practice Cost Index, or GPCI, and proportion of uninsured patients that the system treats. Outliers at the 1st and 99th percentile are excluded from this program. The target price is then calculated by applying a discount to the benchmark price. So during the first 2 years of this initiative, the discount was 3%, but it's not clear what it's going to be in the future. So let's bring the pricing together. Benchmark price is calculated based on the historical fee-for-service expenditures. It's then adjusted by the patient case mix based on a number of different factors, and it's also adjusted by peer expenditure trends. So if you're an outlier and your costs are a lot higher than what CMS has determined to be your peer hospitals or systems, that may bring the target, or benchmark price down. And then the target price takes the benchmark price and applies an additional discount to that. Physician group practices are treated a little bit differently under the BPCI Advanced program. So a lot of episodes performed by physician group practices were initially lumped under the hospital bundles because physician group practices didn't participate at as high a rate in the original program. But now BPCI Advanced incentivizes physician group practices to participate. Physician group practices get their own target price. It's calculated based on historical cost at each hospital that the PGP utilizes. And if the PGP target price is lower than the hospital price, then BPCI will split the difference between the two. And so your target price becomes the average of the two at each hospital. Payment reconciliation is a semi-annual process. The fee-for-service expenditures are compared against the target price and are netted for each episode initiator or provider. So all payments are netted across the episodes of care for each provider, and then the positive or negative reconciliation amount are adjusted based on quality performance. These adjusted reconciliation amounts are then netted across the entire PGP or hospital, and the adjustments are capped at 10% for a hospital or 20% for each provider within that system. So let's summarize in terms of what's different between the BPCI Advanced and BPCI programs. It's important to look at these trends because this might give us a little bit of an insight into where things are going and what CMS prioritizes. So BPCI Advanced has 90-day bundles, whereas previously BPCI was more flexible and offered participants 30, 60, or 90-day bundles. There are a lot fewer exclusions, and 10% of the payments are placed at risk to quality metrics, whereas quality metrics were not originally a part of BPCI. So this was added during BPCI Advanced. Outliers are limited to 1% and 99th percentile, whereas previously there was a number of other options. There's also no phase-in period, where previously participants were kind of sheltered from the risk of the program. Now participants are expected to be pretty well versed in BPCI advanced pricing and program in general. The pricing is prospective, and the target prices tend to be more aggressive than the original BPCI. Incentives for PGP enrollment, so there's going to be a lot more physician group practices that enroll with BPCI advanced, and this may hurt hospitals in the long run because a lot of those episodes may be pulled out from the hospital BPCI advanced reimbursements. This also qualifies as an advanced payment model under MIPS and the APM tracks of MACRA. So that's also a change. In summary, BPCI and BPCI Advanced are payment programs designed to distribute risk amongst multiple stakeholders within the healthcare system. They tie reimbursement to cost and quality metrics, and BPCI Advanced tends to increase the risk to participants relative to the BPCI original structure, and it also tends to create a more standardized workflow, but again, at the expense of customized risk stratification strategies. Thank you so much.